We now move on to the panel discussion. I would like to invite the moderator for this panel discussion, Dr. Chirag Desai, consultant medical oncologist from Ahmedabad, to start the panel discussion and invite the panelists.
Thank you very much, organizers, for involving in this wonderful session. I hope I am audible and my slides are visible. I have been instructed by the organizer to restrict to 20 to 22 minutes because of the delay. So I request all my panelists to give the clear and crisp answer. We want to cover a few things. I mean, immunotherapy in neoadjuvant therapy is a new thing. And before we discuss any new thing, I think let us re-examine our roots, that from where we are coming and where we are going. So my panelists are Dr. Anuj Gupta, Dr. Nizamuddin, Dr. Yashwant, Dr. Hollis, and Dr. Aisha, and I hope that all of them are present in the panel right now.
Yes, sir.
Dr. Nizamuddin is a surgical oncologist, and all other are medical oncologists. Today's discussion will quickly look at the concept of neoadjuvant therapy in NSCLC. We will also have a good discussion on neoadjuvant chemotherapy versus immunotherapy, as well as a couple of slides on neoadjuvant radiation. And these are the various trials that we are going to discuss in today's presentation. So, where are we starting? We know that lung cancer is a bad disease. We very rarely ever see that in stage 1A, but if we do that, the survival is around 80%. If we go down to stage 3A, the survival is less than 40%. 40% also, I think, overstatement. And how do we increase the survival? By giving chemotherapy before or after surgery, and that improves the survival by about 5%. So there is a large room for improvement by doing anything that is possible. And we have done a few things, and we will do what we have done. So my question will start with Dr. Nizamuddin. That which are the patients that in your practice you will consider for adjuvant chemotherapy?
Any patient with tumor, any patient with limited mediastinal nodes, that is a single station mediastinal node detected with the invasive mediastinal evaluation, or any resectable, any doubtful resectability where we think that downstaging will be beneficial.
Dr. Nizamuddin, my question is for adjuvant and not neoadjuvant right now.
Okay, adjuvant.
Yeah.
Yeah. Any patient with a tumor size more than 4 centimeter after surgical resection, or any node positive patient, any mediastinal or hilar node positive patients, usually we prefer for adjuvant chemotherapy.
Good. There is little controversy, little contradiction when we will give rather adjuvant chemotherapy. So Anuj, we can see in some of the slides that adjuvant atezolizumab has already been made its way in NCCN guidelines. So quickly, if reflected in one sentence, that which are the patients where you will consider adjuvant atezolizumab?
Okay. Sir, the patient who are having a tumor burden and N2 disease, which are having a bulky disease, bulky nodal disease, in such patient, we would like to give adjuvant atezolizumab.
Sir, any stage 2A to 3A and PDL1 more than 1%. That is what is actually was for atezolizumab.
Exactly. Yeah. So, are you convinced? That was Dr. Yashwant, right?
Ashay, sir.
Ashay, okay.
Yeah.
So, Ashay, are you convinced with atezolizumab data as adjuvant therapy?
No, sir. But that is what is actually NCCN recommends.
Exactly.
But
Exactly.
there is not actually,
Yeah.
if you look at the separation of the curves, is not great really when you look at the adjuvant chemotherapy versus atezolizumab actually.
Right. So, Hollis, Dr. Nizamuddin just started discussing about candidates for neoadjuvant chemotherapy. So, what is your take on that? Which are the patients who should be given neoadjuvant chemotherapy rather than adjuvant chemotherapy?
Sir, N2 disease is what? And I think poor surgical candidates, because they might not tolerate adjuvant chemotherapy as good as neoadjuvant chemotherapy.
So, these are the patients, right? Stage 3A, T4, and N01, where either you will give concurrent chemoradiation or chemotherapy followed by surgery. And if there is non-invasive T3 with N2 nodes, either definitive chemoradiation or induction chemotherapy.
Yes, N1
Is that
I
correct?
feel is a gray zone, but N2 definitely I'll prefer induction chemotherapy rather than chemo RT. It's what I feel. If the surgeon is confident that it is going to resect.
Right. The question is to Dr. Nizamuddin. Uh, will you be happy with chemo radiation, or you will just want to go for chemotherapy before you take the patient for surgery?
I'll be happy with the neoadjuvant chemotherapy rather than chemoradiation.
Right. And can you tell me what are the possible reasons for that?
There is increased chance of surgical morbidity as well as the presence of pneumonitis from neoadjuvant chemoradiation is what is alarming.
So, Dr. Yashwant, there are some trials, and even in NCCN, concurrent chemoradiation, or it has been written as the treatment before surgery. So, what is your take on that? Will you ever give concurrent chemoradiation? We are coming to the trial that has been presented, but what is the general impression? Dr. Yashwant is there?
Sorry,
Yeah.
can you please repeat the question?
So, will you give neoadjuvant chemoradiation to any patient? And
Uh,
what is your take on the available data on that?
uh, Sir, for neoadjuvant chemoradiation, I will not give. I will go for in such patient in Pencost tumor only. We generally go for neoadjuvant chemoradiation. Other case in T2 single station when surgeon are not confident, I will give anesthetic only.
Great. So I had the opportunity of discussing the same issue with multiple people within as well as outside the country. And even though it has been mentioned in literature as well as in NCCN guideline, concurrent chemoradiation as neoadjuvant therapy is hardly ever practiced in the real life clinical practice. So, Dr. Yashwant, to you only, why will you give any treatment before surgery if the patient is resectable? Why neoadjuvant and why not only adjuvant? Some reasons have been mentioned over here, but if you can elaborate on that.
In many cases, we discuss such cases in tumor board. So, sometime our surgeons are not confident about in single station disease, or we due to dates and other thing also. So, such patient I consider for giving chemo.
Hollis, any other addition to what Dr. Yashwant already said?
Sir, I feel patient fitness. If the patient is able to tolerate it, definitely I'll give a chemotherapy prior to surgery rather than chemotherapy after surgery. There are other things that we can always consider. The reason why NSAID is given other biologies as well that target the micrometastasis early. But I feel the most important is the performance status, because looking at these curves, we know that neoadjuvant or adjuvant, the OS is the same.
Right. So if you look at the table on the bottom of this slide, that received full dose of chemotherapy was 78 versus 63%, neoadjuvant versus adjuvant, all cycles of chemotherapy 91 versus 78%, and grade 3 or higher toxicity was higher in adjuvant chemotherapy. But if you look at the DFS and OS, it is nearly superimposable. There is hardly any difference. So we should give either adjuvant or neoadjuvant chemotherapy. And now, what we are going to discuss next is how we can add on what we already achieved with adjuvant or neoadjuvant chemotherapy. And we just heard that neoadjuvant chemoradiation is not popular, and that came out of this trial as well. Even though, as the presenter rightly said, that this was about the patient who required sleeve resection, were likely having a higher tumor volume. It was a retrospective study, and it showed that 90-day mortality was higher and the survival was not different. And I think we have already discussed in our group. So we are not discussing any further on this particular trial. So what about neoadjuvant immunotherapy? And I want Akshay to answer. What is the rationale of giving immunotherapy ahead of surgery?
Yeah, so basically, as we always say, So whenever we give chemotherapy, there may be down regulation to the T cells or Treg cells that also happens, and that is more likely to have a micrometastasis in the future, post-operatively. So by giving immunotherapy, maybe the hypothesis was, you basically, what you can say, enhance T so that, the effect is much better. And other thing is that even giving chemotherapy along with also means, because the thing is that if you look at it, the immunotherapy alone hasn't that impact if you actually see the immunotherapy combined with the chemotherapy. So if that is done, basically, that exposes the tumor antigens to the immunotherapy and maybe better upregulation of the T cell immunity. So I think that is something which is a rational. But only thing is
So,
that at the end of the day, patch CR, whether it will transmit to the overall survival or PFS, that is what is most important thing.
right. So there is good theoretical background for offering immunotherapy ahead of surgery, because large burden of the tumor will activate the immunity more as compared to that we can achieve after surgery. And that has been seen in the animal models by improving the survival. So we will examine in next maybe 10-15 minutes whether it happens in the clinical trials as well or not. So there are multiple trials which have already been either presented or published. Immunotherapy, monotherapy as neoadjuvant therapy, 6 trials, phases 1B and 2. Combination immunotherapy, there are 2 trials, phase 2 trials. Combination immunotherapy and chemotherapy, we have maximum data, but a lot of things are not yet available in the public domain. 10 trials, phases 2 and 3. Only one trial is available right now for discussion. And combination of immunotherapy and radiotherapy, 3 trials. We will be discussing one of these trials. And these are phase 2 trials. So, intention of any neoadjuvant or adjuvant therapy is cure, and the gold standard endpoint is improvement in the overall survival. But the surrogate is improvement in the disease-free survival in most of the trials across the tumor types. In neoadjuvant chemotherapy, in some of the diseases it is PCR, while in neoadjuvant immunotherapy it is major pathological response. And the question is to Anuj, uh, whether you agree with this endpoint.
Okay, for neoadjuvant immunotherapy, in most of the trials, major pathological response has been taken as an endpoint, because definitely for a curative setting, we cannot follow the patient for a long to wait for such an important decision making. Major pathological response is any response when the viable tumor size is percent residual tumor percent is less than 10%. So, in many other trials before, also in other organ-wise DMGs, we have seen that the pathological response, which is not a complete response, have not turned out into the overall survival benefit. So, at this point, we are although taking this major pathological response as a surrogate marker, but definitely it has to be validated and it has to be established as a standard. And at simultaneously, we should also look for the other endpoints which can better define across all the trials.
So, Dr. Yashwant, are you happy with this table that HR for death, this is the indirect mirror for survival itself? If the percentage of residual viable tumor is 1 to 10%, that is major pathological response. If we call it 1, with any higher amount of the residual disease, it is exponentially increasing. So it is best to induce PCR, but MPR is also a good surrogate marker. Do you agree with that?
Uh, as Dr. Anuj said, it has to be validated in longer trial.
Yeah.
But I'm not happy with this. Based on that, those who I'm no, because patient who are not getting, as per this data, patient who are not getting good response, they are doing bad. So
So,
for
Dr.
such
Nizamuddin.
patients,
Yeah, okay, thank you. Dr. Nizamuddin, if you have the patient who is T2 and 1 operable patient, um, and you know that the patient is definitely going to require adjuvant chemotherapy, but will you submit that patient to neoadjuvant immunotherapy? And if so, it will be based on what endpoint that you see in the clinical trial? Is it MPR, PCR, DFS or overall survival? What will be your standard reason for accepting that trial in your practice?
So the results coming out of the neoadjuvant immunotherapy are very promising with a very high MPR and PCR as well. But the long-term results are awaited. Hopefully, they will also result overall survival as well as progression-free survival. Till the data gets mature and more results are available, we cannot accept neoadjuvant immunotherapy as a standard in our practice. As of now, if a patient is someone with a T2N1 lung cancer, he is very well a candidate for upfront surgery followed by adjuvant chemotherapy. So at present, at present in clinical practice, for a patient with a T2N1 disease, upfront surgery will remain the standard of care, followed by
Agree,
adjuvant
yeah.
chemotherapy.
So, great. So, with upfront surgery and adjuvant chemotherapy, we can improve the survival from 50% to 55%. And we will try to figure out in the next few slides whether we can improve it from 55% to 60% or not. Right? So, for that minimum data that I will want to look at is MPR and DFS. I will not change my practice only looking at MPR. I will also want to look at DFS, and I don't want any discussion on this particular point. Everyone will have a chance to comment towards the end of the discussion, and maybe you can point as well. So, immunotherapy, monotherapy, we already heard that there is phase 1 trial of pembrolizumab, NK3475, 223, and I think a lot of water has flown in Ganges, so we don't need to waste a lot of time on this particular study. It was stage 1 and 2 NSCLC, and it only showed that it is feasible, and almost 40% or 44% of the patients were having a major pathological response. It was irrespective of the study based on very small number of patients. So it only says that the drug works, and it works in some patient. We don't know in which patient does it work. So then there are number of phase 1 and 2 studies exploring various neoadjuvant PD-L1 or PD-L1 monotherapy, giving the patient nivolumab or sintilimab or atezolizumab, one of these drug, and MK3475 is right here. And endpoint in this patient is safety, feasibility, MPR, R0 resection rate, and so on and so forth. If you look at the combination of immunotherapy, there are 2 studies. Each of them is looking at Nivo-EP combination. And if you look at the result of some of these studies quickly, small number of patients in each of these study, and various proportion of the patient having squamous cell carcinoma, a different distribution between stage 1, 2 as well as stage 3 patients. If you look at the percentage of the patient taken for surgery, in each of the immuno-oncology monotherapy, it is around 90 to 100%, while for dual checkpoint inhibition, it is 67% in this trial, 81% in this trial. Remember that, that's important. If you look at the PCR as well as MPR, just focus on MPR, it is 30 to 40% on immunotherapy as monotherapy, and PCR is around 10%, while here the PCR is 33%. In spite of having fewer patients taken for surgery, the PCR is exciting. So we need to figure out what is the reason and how we can overcome this reason. How can we improve the resection rate in these patients? But we are not going to discuss that because that is not the main point that we are discussing right now. Biomarker correlation is poor in most of the studies. With PDL1, there is correlation seen in a couple of them, and TMB, it is seen only in one of them. So we don't know which are the biomarkers. So the question is to Hollis, theoretically, can addition of chemotherapy improve the efficacy of immunotherapy?
Yes, so theoretically, it is going to increase the effect of immunotherapy. You have a bulky disease at baseline. Immunotherapy is going to expose the antigens. There's going to be more of tails coming in. So theoretically, yes, adding immunotherapy to chemotherapy is beneficial.
So we'll examine in next few slides whether it actually happens or not. And we have the Nadim Shravan, we have Nadim trial. We will listen to what Shravan says little later. But what Nadim says, Narmada excellently discussed that. And if you look at the MPR, if you remember the previous slide, the MPR was around 30-40%. while in this particular trial of 46 patients, small trial, MPR is excellent, 83%, and PCR also is excellent, 63%. So, Dr. Nizamuddin, if you had this trial as a phase 3 result, will you accept and submit neoadjuvant immunochemotherapy to practically all the patients?
So this trial is it's a small trial. It's a phase 2
Yeah.
trial, but the results are very promising. Actually,
Right.
we have to admit that the MPR and PCR rates are very promising, as well as the 3-year overall survival.
Right.
It's intention with the intention criteria analysis. It is around 82%, and with per protocol analysis crossed 90%. And another main point about this trial is most of the and almost all of the patients were in the stage 3. Majority of the patients were in the stage 3,
That's correct.
and
That's correct. Yeah.
majority of this stage 3 patients, stage 3, more multiple VDAS node
Yeah.
positive. So overall, looking this trial shows a very good promise, but it's a very small trial and it's a phase 2 trial. I think we have to wait for other phase 3 trials to show up the results.
Right. So Nadim Shravan is the musical melodies. They are the musicians. This is what Nadim says, and this is what now Shravan says. He is telling something different. So there is a phase 3 clinical trial,
Sir,
checkmate 816.
sorry to interrupt, sir. We've run out
Yeah.
of time, so request you to conclude the panel discussion quickly.
So, okay, so let me quickly go through Nadim, this checkmate 816 trial. The primary endpoint was PCR and not MPR, and that was seen in PCR was seen in 24% of the combination patient and 36.9%. This is opposite as compared to Nadim trial. So, Ashay, any comment on that? Why should there be such a vast difference?
So basically, sir, I always feel whenever we are using immunotherapy, even neoadjuvant adjuvant setting, we are struggling with the biomarkers, basically.
Yeah.
So what exactly the biomarkers? Even if you look at the Nadim trial and you look at even the CPS, basically, more than, I mean, they try to put a various cutoff, and even less than 25% they are more response rates. Even the PDL1, which is, if you look at even the pembrolizumab trial, in the standard we use pembrolizumab as an upfront marker, PDL1, but there was no PDL1 correlation was also there. So if you really look at, I don't think we have understood a biology adequately enough to give neoadjuvant therapy in the, what you can say, neoadjuvant setting. But having said that, I think the chemotherapy plays a vital role when combined with the immunotherapy setting.
So, Dr. Nizamuddin, this trial shows that the surgical outcome is not much different. Do you agree with that?
Yes, here the PCR rate is not as much as the Nadim trial. PCR rate has come down to 24% in the neoadjuvant immunochemotherapy arm as compared to
Right.
63% in the Nadim trial. So this trial looks
So,
more of a real world scenario. For the long term outcome, the checkmate 816 trial as well as other phase 3 trials to reach a
so
definite
at present, yeah, agreed. So at present, we have multiple phase 3 clinical trial. We have the early trial of only 816 study, and that is not same as what Nadim was telling. So let us wait for the other phase 3 clinical trials, and that will be very important to look at. And what about immunotherapy and radiation? Maybe in 1 minute, Dr. Hollis can tell about that.
Sir, it is an early trial. I'm not very sure whether it will stand the long run, because Durva is definitely better in an adjuvant setup post, but maybe in the new adjuvant setup, maintenance, not very sure whether it will help.
Right. So this is my concluding slide. Look at the second point. Preoperative PD-1 inhibitor is the safe, feasible, and associated with MPR of 20 to 45%, and that can be improved by addition of chemotherapy. And we don't have any more data in addition to this particular data. So future will tell us about how we can incorporate immunotherapy in the neoadjuvant trial. Thank you very much from my entire group. And let us have a quick half-minute comments from each of the panelists. Dr. Anuj?
Okay. Thank you, sir. I think the data from the available presently are quite encouraging, and it will clear definitely that this immunotherapy will have a neoadjuvant role in the coming era. But again, we need to look at the proper endpoints, and we need to get a another important question which has to be asked is whether in the adjuvant setting what type of chemotherapy or immunotherapy is required. So there are certain questions which are to be answered, but
Okay.
still this is a promising aspect of the lung
Definitely.
cancer.
Yeah. Dr. Nizamuddin, quick comment.
Yes, the immunochemotherapy and immunotherapy seems promising, but one thing noticeable is the absence of an upfront surgery on any of these trials. If you look at the Nadim trial, they are given adjuvant immunotherapy as well. So it becomes difficult to tell whether the neoadjuvant immunotherapy or adjuvant immunotherapy, which has a greater impact on survival based on these trials. So there is always a possibility of upfront surgery in early lung cancer followed by adjuvant immunotherapy, which is not tested in any of the
Right. There are
trials.
trials in that extent as well. Dr. Yashwant, quick comment, half a minute.
Sir, immunotherapy has any well established in metastatic setting. Seeing this data, I am very much optimistic that definitely surgeon's perspective will be changed.
Let's hope so. Dr. Hollis.
Sir, definitely two, three things. First is good biomarkers. We need to determine whether PDL1 or TMB. My preference would be an N2 disease. An interim endpoint, maybe looking at the checkmate trial, radiological response is discordant to the MPR. So maybe MPR, but not the radiological response. If my surgeon is not sure of the radiological response, he might not operate. He might send it for radiation. And definitely adjuvant, as the surgeon has pointed out, adjuvant immunotherapy, the role of adjuvant immunotherapy in that. So these three things need to be sorted out. Then I'll be convinced whether Immuno is going to work or not.
Dr. Ashay.
So I agree with. See, the thing is that if the surgeon said is upfront operable and can operate, I will not give a neoadjuvant chemoimmunotherapy at this particular juncture. Only patients where neoadjuvant has been advised, maybe dates, maybe because of the performance status where they wanted to optimize the patient before surgery. These are the patients. And as Holly has pointed out, maybe N2 disease where I will give. But as of now, I will rely upon maybe the adjuvant maintenance immunotherapy at this juncture.
So at present, we have only one phase 3 clinical trial. At least 3 or 4 of them are ongoing. And let us look at them. If these 3-4 trials are able to convince us, hopefully in the next year, next December, we will discuss that we will want or not want to give immunotherapy all the patients in adjuvant. With that, yeah. So thank you very much for involving us in this wonderful discussion. Thanks to all the panelists.
Thank you, sir. Thank you to all the speakers and the chairpersons of this session. For the next session, I would like